Dr. Prashant Gowda, Secretary NNF Karnataka State Chapter. It's my privilege to continue the session which we have started, the web series, the masterclass from National Neonatal Forum Karnataka Chapter. I would like to again give you a warm welcome to all of you who have been consistently being part of this wonderful journey of web series which we have started from last 2.5 months. So today we have two most important topic and very relevant topic for all of our day-to-day practice. And I'm really happy that we have got two wonderful speakers and they have made a lot of efforts to make a video, to make a presentation better so that the participants and the audience get benefited. So I request our National Neonatal Forum India President-elect Dr. Ranjan sir to introduce the speaker, and I request them to give the green signal to start the session. Over to you, Ranjan sir.
It's my pleasure to introduce Prashanth. Dr. Prashanth URS, I've known him from nearly 3 decades now. Yes, 2.5 definitely, probably 3 decades. We were together in Ramaya, and we had a wonderful time there in the Department of Pediatrics. And I then went out of Ramaya to start our own unit with Dr. Janaki. Dr. Prashanth continued there, and he took the burden of running the NICU there for a long time. And then he went to Australia and got himself more acquainted with the recent developments and all those things happening in neonatology. Australia, as you know, is maybe about 10-15 years ahead of India as far as neonatology is concerned. So after arming himself with all the knowledge and the skills, he came back and joined Apollo. And ever since then, he is running the neonatal services of Apollo Hospital, as you all know. Prashanth is also the past president of the NNF Karnataka, and he's very well known to all of us. And he's a upright man who doesn't hesitate to call spade a spade. With this simple introduction, I request Prashanth to start his talk. This is a topic which is very, very important. Day-to-day practice, we need this. And I hope all the fellows and the postgraduate students have made time to listen to both these talks. Thank you.
Thank you, Dr. Ranjan sir. It's been a pleasure to see you and hear you after a long time. Am I audible?
Yes, yes, you're very well.
As you said, it was a pleasure working with you also those days, and we still remember all those wonderful time we spent. Anyway, without much ado, I would like to thank the National Neonatology Forum Karnataka for giving me this opportunity to cover this important topic. And I would like to thank Dr. Kotaresh sir and Dr. Prashant Gowda and Dr. Dinakar for all the efforts they have put in to make this webinar such a success. To begin with, my endeavor for this talk has been to make it as practical as possible. So, because it is something which we require in a day-to-day practice, and it should help one and all. So let me begin the session. The outline for the talk today is what I'm trying to do is talk a little bit about the modes of ventilation, the newer patient-triggered ventilation, volume ventilation, clinical relevance of the modes, different modes, preparing a neonatal ventilation protocol for the unit, and finally, there is also a video demonstration of how to use these units. So I hope you'll all be patient enough to be with me. To introduce, I think we all know that mechanical ventilation is something very close to any neonatologist's heart. The goal is to oxygenate the baby when the baby is struggling for oxygen, remove the carbon dioxide with minimal damage to the lungs, and the pathophysiology of the lung damage due to mechanical ventilation is multifactorial, as we all know. The VILI, or what we call as the ventilator-induced lung injury caused by mechanical ventilation, contributes to significant morbidity and mortality in the neonates, and especially when we don't do it the right way. The general principles of mechanical ventilation is first is to improve the lung compliance, reduce the oxygen requirement, prevent surfactant inactivation, see that there is a even tidal volume distribution by recruiting optimal lung volume, preventing of atelectasis, and lung protective ventilation strategies like mild permissive hypercapnia, minimal FiO2 to reach a target of 88 to 93% of oxygen. And there is no evidence to support routine use of sedation and muscle relaxation. This is one big change what we see compared to what we used to do for ventilation before, where we always wanted, when we were doing the conventional ventilation, we wanted the babies to be quiet. But now, after the patient-triggered ventilation has come in, there is no evidence to support the routine use of sedation until unless the baby is struggling too much, because if you sedate the baby, the triggering will not happen and the babies will not have the normal physiological breaths. So that is one of the things which has changed. Of course, muscle relaxations and all those things are specific to certain conditions like PPHN and those situations. That is different. I'm just talking about the routine ventilation. The baby should be, as I said, baby should be allowed to breathe spontaneously. Routine suctioning should be avoided because this leads to de-recruitment, transient hypoxemia, and perturbation of cerebral hemodynamics. What I mean by routine suctioning is some units have a protocol that every 2 hours, religiously, they do the suctioning. So this may not be required until unless there you see some block, or if you see some change in the tidal volume when you're seeing the ventilator dashboard, or any other indication which makes you feel that you need to do the suction. If the secretions are detected, gentle rapid suctioning without installation of normal saline is indicated to prevent further problems with these babies which are already on ventilator. The other important thing to follow is the open lung strategy, which is very crucial for lung protective ventilation. The mechanical ventilation, as we all know, is highly specialized. So there are different modes of ventilation. But one thing we should remember, even though there are different modes of ventilation and different names which have been given to these different modes, many a times they are all doing the same job. It is because the ventilator manufacturers, many times they want to circumvent the problem of patent, because of which they give these proprietary terminologies, whereas the function is almost or the same as what any other ventilator would do. So don't get confused with those modes. That is why what is important is you know to know your ventilator thoroughly. Then only you will know that there is not much of a difference between whatever other mode which the other ventilator has got. Intubation criteria, I think most of us, most of the people who are hearing here are all from neonatal background, they would be knowing, so I won't go into much of that. There are two types of basic types of conventional ventilation. One is the positive pressure ventilation, the time limited positive pressure ventilation, where the ventilator limits or supports till the pressure is set by the, as to the pressure set by the operator, and it overcomes the elastic or the resistive forces of the deceased. It also opens the lung to deliver a volume of air or oxygen. The second mode, which has come recently over the past decade or so, is the volume ventilation, which is gaining a lot of ground and which has got enough evidence that volume ventilation is the way forward. The ventilator tries to deliver the volume set by the operator. Advances in the microprocessor make it possible to deliver even very small, minute amounts of volumes of gas. Volume trauma, which is a major cause for the lung damage, can be prevented. Currently, as I told, volume ventilation is the preferred modality. The time cycled ventilator, this change the inspiration to expiration is dependent on the time set by the operator. That means you are setting the inspiratory time. If you set an inspiratory time of 0.3 or 0.4, that will be the fixed inspiratory time which the ventilator will give the breath. Now you have the other one. This is the recent, one of the recent advances is the flow cycled ventilator. This is also called as flow interrupters. It is also called as the flow termination. So different terminology, but at the end, they all do the same thing. What it means is when the baby is breathing, many a times when the baby is on ventilator and when the baby is getting a ventilator breath, suppose the baby wants to breathe out, it will not be able to do because the ventilator will be giving the breath. So this causes a lot of asynchrony. Now, in this flow interrupter method or the ventilator, the moment the baby wants to breathe out, the ventilator will sense it. And as soon as it senses, it interrupts the flow. That is why it is called as the flow interrupter. So the moment it interrupts the flow, it allows the baby to breathe on its own. So that is why it is called as the flow interrupter. And what happens in the flow interrupter is you can see that the inspiratory time is set by the baby itself. So we set a backup inspiratory time, but the baby will set the inspiratory time whatever it requires. And this is a major reason to say that this is one of the most physiologically beneficial mode of ventilation for the neonates. As we all know, probably all of you would have seen this. This is a very important development, that is the flow sensor. The flow sensors, these are attached to the endotracheal tube, and it detects the negative flows from the baby and triggers the baby to breathe. Now, synchronized ventilation is another thing which has come over the past decade or so, and which we never had before. When we had the bear cubs and the infant stars and those ventilators, we never had this triggering and all those things. It was just set the PIP, PEEP, rate and FiO2, and that is it. We were done with it. But now we have so many things to do with these ventilators and so much of advances, and it has made the ventilation so smooth, and it has become more beneficial and also safe for the babies. One of those modes, one of the development is the triggering. We have umpteen number of papers saying that the triggering or the synchronized ventilator breath definitely helps for these babies. Synchronization has been shown by several trials. Setting a low trigger. Now the art is how much trigger to be set for these babies. Always you should make sure that you set such a low trigger that the ventilator can sense every breath of the baby. That way you'll be able to assist each and every respiration or every respiratory cycle or the breath cycle the baby is having. And apart from triggering, the other important thing from this flow sensors is that it gives a lot of information for us. It gives us a lot of tidal volumes, it gives the minute volume, it gives the compliance, it gives the resistance, a whole lot of information of what is happening to the baby or what is happening when you are ventilating. Now, as I already told, setting the trigger sensitivity should always, I will show you in the video demonstration how to set the trigger sensitivity also. One thing you should always be aware is that when you are doing trigger ventilation, avoid the water within the circuit, because this may get misinterpreted by the flow sensor as an onset of breath, and it will happen, multiple triggering may happen, and it may lead to the asynchrony. The circuit should always be kept free of condensed water. The flow sensor always should be positioned with the plug pointing upwards. This is one of the tricks which has been recommended to reduce the condensation in the circuit. Now, what I am showing here is, sorry for the quality of the image. Anyway, I'll be showing it to you later in the demonstration. So this is what you're seeing here is in orange color. This is a baby who is on the patient triggered ventilation mode. Now, whenever the wave becomes orange, this is on SLE, whenever the wave becomes orange with this dip, that means the triggering is happening. So this is the initial trigger following which the ventilator breath is continued. So that is how you know that the triggering is happening. So these are the different types of modes of ventilator. The regular IMV, or what we call a CMV, continuous mandatory ventilation or intermittent mandatory ventilation. You have to set all the things, but one major difference is synchronization is not there in this mode. If you want, you can add the triggering in the recent ventilators which we have. SIMV, here the spontaneous breaths of the baby will be assisted, but you have to set the rate. Now, suppose you are setting a rate of around 60. So that 60 breaths will be assisted by the ventilator. Every time the baby is breathing, the ventilator will sense and it will give an additional, it will assist the breath, and 60 breaths in a minute it will assist. Suppose the baby is breathing more than 60 times, it is breathing around 70 times or 80 times, the remaining breaths will not be assisted. Okay, so this is one of the modes which is used regularly, and it is usually used to begin the ventilation. It is more of a beginning of the ventilation. Many people prefer to use SIMV. Now SIPPV, this the synonymous names for this is SIPPV, that is synchronized intermittent positive pressure ventilation, assist control, or patient triggered ventilation. So all mean the same. This has gained a lot of popularity of late, with so many trials showing that this is a much better uh, or much baby friendly sort of mode of ventilation. And in this, what happens is you need to set everything like as you do in the SIMV, and it is also a synchronized mode of ventilation. The difference is that if the baby is taking around 60 breaths, all the breaths will be assisted. So even if you keep a backup rate of around 40 or 50, only if the baby is apneic, then that 40 or 50 breaths will be given. Otherwise, depending upon the baby, whether it wants 40 breaths, if it is breathing 40 times or 60 times, the baby will, the ventilator will support each and every breath. This has been used very extensively, both as an initiation mode, and also it is very comfortable to use this mode for weaning, because the main advantage in this is you don't have to meddle with the rate. So if you just bring the pressures down to the minimal settings, and if the baby is comfortable with minimal FiO2 and minimal pressures, probably you can straight away go ahead and extubate the baby. The other mode is pressure support ventilation. In the pressure support ventilation, as I already told, it is one of the flow termination mode. What happens here is, whenever the ventilator senses that baby wants to breathe out, the ventilator will cut off that breath which it is giving, so that the baby can breathe out. So in the bargain, the baby will set its own inspiratory time, and as a result of which, this has been found as one of the most physiological type of ventilation for the neonates. So I think I've just explained the same thing for pressure support ventilation. But when the preterm neonates have extreme preterm babies, where the inspiratory time may be 0.25 or less, in those situations, sometimes this mode may not be very useful. So that's what extremely preterm babies may not have effective inspiration time given their stiff lung. So in that situation, the PSV mode may not be very helpful. So this is one of the, what do you call, a little bit of a complex mode where you have the SIMV with pressure support. So this is mainly, generally this is not used very frequently, but some people like to use it for weaning. So this is a synchronized breaths or time cycled and spontaneously untriggered breaths or flow cycle. That means the synchronized breath, when you set the breath, whatever breath the ventilator is synchronizing with the baby, that will be SIMV. And the ones which are triggered without synchronization, or the baby is breathing on its own, will be on pressure support ventilation. So this is it's a bit of a complex support strategy, which generally is not used, but may be beneficial in some situations where we are finding it very difficult to wean the baby from the ventilator. So when you put them on this ventilator, you need to set the pressure support, how many percentage of the breaths will be pressure support, how many of them, what is the flow interruption, at which level you should do the flow interruption. All these settings will have to be done. Now, pressure versus volume ventilation. So I was talking about the triggering, the patient-triggered ventilation, and the modes where it is mainly pressure. Now, we all know that this is one of the studies, the International Survey of Volume Targeted Neonatal Ventilation in archives, where they have found that it is an international survey where they found whether how many units are doing volume ventilation, how many are doing pressure ventilation, what is the benefits. We all agree that the neonatal injury may be more related to over distension due to the tidal volume delivered than the pressure-induced barotrauma. So when appropriate tidal volume is delivered, the pressure is not related to the lung injury. So this inadvertently giving high pressures can be controlled. Despite evidence for the benefit of volume targeted ventilation in preterm infants, this is one thing which I really want all our people to really emphasize, is that in spite, all of us know that volume ventilation is very good, volume ventilation is the way to go forward, but even in the international and all over the world statistics when they have taken, it's only around 50% of the large neonatal units use this technique. Probably this percentage should change in future. So as you see, the advantage of pressure versus volume control as depicted in this graph, with the improvement in compliance in the pressure limited ventilation, the delivered pressure increases. As the lungs becomes less stiff, the pressure starts increasing in the lungs. This causes the barotrauma, whereas in volume controlled ventilation, as the volume is reached, whatever set volume is reached, the pressure automatically comes down and the barotrauma or the pressure induced injury will be reduced. That is a major advantage of volume controlled ventilation. So these are the different types of trauma which can happen: barotrauma, volume trauma. Where barotrauma, when there is excessive inspiratory pressure, it causes alveolar damage, pulmonary edema. Volume trauma causing disruption of alveolar cells, epithelial and endothelial cell. Atelic trauma, its shearing effect on the alveoli, reopening of the lung units, more expansion of some lung units. Biotrauma, this is inflammation or infection which causes ongoing lung inflammation. Rheotrauma, inappropriate airway flow, that is if there is turbulence, excessive flow, excessive PEEP, lung overinflammation, all these things will be caused due to rheotrauma. So these are, it is not only barotrauma and volume trauma, there are several other types of trauma which can be caused to the lungs if they are not addressed properly. Now this is a very interesting table where you'll get to know all the modes in one look. So the conventional ventilation, time cycle pressure limited ventilators, modes are IMV, SIMV, SIPPV. Flow cycled pressure support, what I already told, flow cycled or flow interrupter, whatever. So that is the pressure support ventilation. Now the time cycled and flow cycled, that is SIMV plus PSV, this is a hybrid mode. So when do these become hybrid mode? When you start adding the volume to it. Suppose you have IMV, you add volume. This is generally used. This IMV will be, if you set 60 breaths, it will give 60 breaths. And so that in this, there is this mode is usually used when there is no respiration, the patient is sick or paralyzed or completely sedated. SIMV with volume, this is primary modality for weaning. Primary modality and weaning. So as I told earlier, this is used as a primary modality in many places and for weaning. SIPPV with AC, it is a primary modality and weaning. These two, either one of the two can be used. I will come to that little later, which one is better of the two. And pressure support ventilation, the primary modality, when good respiratory effort is there, this can be used as primary modality, but generally it is advised to avoid in extreme preterm babies. So the hybrid ventilation, now coming to the volume ventilation, there are several types of volume ventilation. There are several names which have been given for this. If you look at it, technically there is only very little difference in what they are doing, but ultimately all of them deliver the set tidal volume. So don't get intimidated by these terminologies and think that this ventilator is better than that or that one is better than this, because ultimately if you look at it, all of them are delivering the volume, whatever you have set, but maybe with a slightly different technique. So that also I will come to that. So these are the different ventilators. You have the Babylog 8000 plus. I think all of us have used it for so many years. We have the VN500, which is one of the new ones, the Stephanie, which is not very popular in our country. SLE 5000, this, I have not seen this. And servo ventilators, which was earlier as Siemens and Philips. See, all these ventilators have volume ventilation. Now here it is called as volume guarantee. Drager calls it as volume guarantee. Stephanie calls this as volume limitation. SLE calls it as targeted tidal volume plus. Now this ventilator calls it as volume guarantee. Now the Siemens calls it at pressure regulated volume control. And this one, Philips calls it as ventilator assisted pressure support. So it is just the terminologies, and it is not really, it's not going to make a big difference. So how does the volume guarantee work? Now, volume guarantee, you set a set tidal volume for the machine to deliver during every breath. How does it know how much to send, how much volume to give? What it does is, every time the baby takes a breath and expires, it calculates the expired tidal volume and it gets an idea how much pressure is required in the next breath to achieve the set tidal volume. So there is an algorithm which is inbuilt in the computer, I mean in the microprocessors of these ventilators, which calculates this, and so it corrects that level of pressure what is required. That is very well shown in this graph. Let me show you that. Yeah. See, now suppose you have a target volume. Now the target volume you have set, say, let us assume that you have kept as target volume of 6. So when it is reaching this level, it means it is the optimal target value. Now the pressure remains the same. Now in this breath, the target volume has reduced. So immediately what it does, the computer senses it, because it has got the expiratory tidal volume and it has already calculated that the next breath, the pressure should go. Similarly, here the tidal volume crosses what you have set. So immediately the next pressure, it reduces to reduce the pressure, and when they start systematically, when this is applied over a long period of time, then this inadvertent of volume, excess volume or excess pressure would be avoided, and this would be very safe for the babies. So coming to the pressure regulated volume control. So this is also one of the volume ventilation. The pressure is adjusted according to the tidal volume delivered. That's what we expect it to do. What it does is, it attempts to use the lowest pressure with a deaccelerating flow waveform to deliver the set tidal volume. How it does it? The first breath is delivered at 10 centimeters of water above the peak pressure. Whatever is the existing peak pressure, 10 centimeters above that it will deliver first. This is a test breath. This will enable the microprocessor to calculate the pressure needed to deliver the set tidal volume based on the patient's compliance. So with this breath, it will calculate what is the pressure required to deliver the set tidal volume. That is how this system works, but ultimately it will deliver the tidal volume what you have set. Now, volume assured pressure support ventilation. This is seen on the Philips ventilator. So here what happens is, a guaranteed tidal volume delivery is provided with each breath. Delivered tidal volume is measured. As I told you, in volume guarantee, it takes the expiratory flow and measures the required tidal volume. Here in this, the difference is the delivered tidal volume is measured when the inspiratory flow has deaccelerated to the minimum set level. So when it goes to this level, it will assess what is the maximum pressure required to give the set tidal volume, and then it delivers that much of pressure. So that is, I think probably I have made it very clear. The volume guarantee or the volume ventilation or the set tidal volume is delivered in different modes in different ventilators, but ultimately all of them deliver, they are designed to deliver whatever volume you have set. The SIMV or SIPPV with volume targeting is the most popular choice in the hybrid ventilation modes. There is concern when you use pressure support ventilation with the smallest babies. The SIPPV with volume targeting as the primary mode is recommended for respiratory distress. The deliver the desired tidal volume using the required pressure, that is usually the tidal volume what we expect to keep is around between 4 to 6 ml per kg. And here I would like to add one thing, that especially in extreme preterm babies, when you are using, it is said that the um, when we in these extreme preterm babies, you'll have to add 1 ml per kg, because the flow sensor will add to the instrumental dead space. And this I'm talking only in the very extreme preterm babies. So if you are calculated around 4 ml per kg, if it's an extreme preterm baby, you need to add 1 ml per kg in addition to that. So SIPPV with volume guarantee works best in the uniform lung disease. It is less effective in unequal lung conditions as PI, bronchopulmonary dysplasia, and MAS. Volume, another very, very important thing is the leak, the ET tube leak. Please watch the ventilator when you're doing the ventilation, and all these ventilators definitely will show you the leak. And if the leak is above 20%, your volume ventilation will not be appropriate, or you'll not be able to give adequate volume to your baby. So the ventilator like SLE and the Dragger, they claim and they say that they have an inbuilt mechanism to overcome up to 50% leak in the ET tube. But even then, generally it is recommended that if you are seeing a more than 20% leak in these babies, then it is better to extubate and re-intubate these babies. So this is one of the Cochrane reviews to show that volume ventilation is better than pressure ventilation. So when they did the volume ventilation, the combined outcome of death or BPD, pneumothorax, days of ventilation, hypocarbia, combined outcome of PVL, all of them showed a decreasing trend, and that's why nowadays it is recommended that volume ventilation would be better than the regular type of pressure ventilation. The essentials of successful volume ventilation or volume guarantee ventilation is the ETT leak should be less than 50%. The PIP limit is set well above the working PIP to allow the fluctuation in the PIP and to avoid frequent alarms. The inspiratory pressure reaches a plateau before expiration. The set tidal volume is high enough to support the infant's breathing effort. The inspiratory time during pressure support ventilation is not too short, that is 0.2 to 0.25 seconds. The circuit gas flow and the PEEP are adequate for the infant's condition. So you need to ensure all these things to be successful in your volume guarantee ventilation. So in the ET tube, if there is a gas leak around the uncuffed neonatal ETT, it varies with diameter, airway pressure, and duration of ventilation. So we have seen many times, probably if you are ventilating for a little longer time, generally after 2 or 3 days, the ET tube which was fitting snugly, after 2 to 3 days, you start seeing there's a leak of around 30% or 40%. So that indicates that not to continue as it is, but you need to re-intubate and put a bigger size ET tube. So this is what I already told. They say that in Dragger and SLE it can be used up to 50%, but still the experts recommend that if you see anything above 20% to change the ET. The low tidal volume alarm. A low tidal volume alarm occurs if the expired tidal volume is less than 90% of the set tidal volume for the duration of the set alarm delay. The number of these alarms may be reduced by increasing the maximum PIP or by setting the alarm delay to more than 10 seconds. The circuit gas flow may need to be increased in order to achieve the required PIP within the whatever set inspiratory time. So these are some of the suggested settings which have been recommended when you use the volume ventilation, the pressure limit, and the volume which you have to use. If it is a preterm baby with RDS more than 2 kgs, then you need to use 4 ml per kg. Preterm infant 700 to 1500, 4 to 5 ml. Less than 700, 5 to 6 ml. As I already told you, as the weight goes down, your tidal volume increases because you need to add that 1 ml for the flow sensor which adds to the dead space. If it's a preterm infant with BPD, what is recommended is 5 to 7 ml per kg. If it is term infant with MAS, 5 to 7 ml per kg. A term infant with CDH is around 4 ml. Term infant with pneumonia would be around 4 ml. And these are the pressure limits which you need to set concomitantly along with the volume. Surfactant treatment. Surfactant administration often causes brief increase in airway resistance and endotracheal tube obstruction. To maintain the set tidal volume, the PIP limit should be set 10 cm or more above the pre-surfactant PIP. Within 30 to 60 minutes, the working PIP automatically falls as the lung mechanics improve, especially if you have set on the tidal volume. Suppose you are doing volume ventilation, and if you are giving the surfactant, because the ventilator will be sensing the tidal volume, automatically the pressure will come down after giving surfactant as the compliance improves. How do you wean from volume guarantee? As the lung function improves, the volume guarantee ventilation automatically weans. So in assist control or pressure support control, the infant is going to have its own ventilator rate. It's going to control. So you are not controlling from the machine. When the set tidal volume is below the infant's spontaneously generated tidal volume, the PIP will be reduced. Infant will be breathing on the ETT like CPAP, increasing the work of breathing and risk of subsequent extubation failure. This is observed for more than short periods, then extubation can be considered. Generally, weaning is recommended if the tidal volume is below 3.5 ml per kg, MAP is consistently less than 8 to 10 centimeters with the set tidal volume of 3.5 to 4.5 ml per kg. Blood gases are satisfactory. With these settings, the baby is maintaining the expected saturation. There is no increased work of breathing. The readiness for extubation can also be used, can also be assessed by using the spontaneous breathing test. After doing all these things, if you feel the baby is still comfortable with such low settings, then you can go ahead and extubate the baby. Splinting is one mechanism which has been found, which has been in fact studied in these two studies and reported also. Generally, it is found that when the baby is on volume ventilation, the babies can actively expire and then tighten their abdominal muscles so hard that they prevent gas entering the lungs during an inflammation, which is termed as splinting. This splinting causes hypoxemic episodes due to low lung volume and low tidal volume delivery. This causes ETT obstruction and low tidal volume alarms. By setting a higher PIP, for example, around 35 centimeters of water, can overcome this splinting, and also using a higher target of tidal volume at around 6 ml per kg has reduced the hypoxemic episodes in studies compared to other tidal volume triggered ventilation modes. These are the characteristics which is given about the Drager Baby Log 8000 and VN500. The only thing I would like to say in this is it is almost similar to this one. Here the flow sensor type is slightly different, is the hot wire anemometer. Then you have the flow sensor dead space. As I told you, it adds to around 0.9 ml almost. The flow sensor accuracy is 0.5 ml of for tidal volume measurement. So similarly, all these things would have been given which you need to be aware if you are using a dragger ventilator. The flow sensor trigger delay, this is another important thing. It is set for 30 milliseconds from the onset of inspiratory gas or the onset of inflammation. When you are doing the ventilation, suppose you want to improve the oxygenation, some of the maneuvers which you can do is increase the inspiratory flow rate, producing a more square wave inspiratory pattern, increase the peak inspiratory pressure, increase the I time, increase the PEEP, increase the ventilator rate, and increasing the PEEP to lung volume, probably the safest, most effective way to achieve a higher MAP. Now, one thing which is very important is the measured values on the right hand side column of the SLE. When you have the SLE ventilator, all these measured variables will be there, and you should watch these things to help you ventilate and for your ventilation to be very smooth. Now, what does each one of them mean? I'll let you know. One is resistance. That is what is called as R. Now, if this resistance, if you see above 300, that means there is a kinked or partially blocked ET. The ET is impinging on the carina. There is a severe BPD or MAS, or during recent Surventa administration, thick secretions in airway, a very high PIP and rate together in, if you are using a 2.5 size ET, this causes high turbulence. So these are the conditions. What it says, if there is a resistance of more than 300, you should get alerted to one of these problems. So this is what happens if the baby is flexing its neck, the ET can get kinked, and by changing the neck position, the problem will be solved. Now, the C20/C, this is one reading which you will see on the ventilator. What it does here is, it measures the compliance of the last 20% of the breath, and it computes and gives the value. And if this value, what they say is, if it is generally, the experts say that if this value is less than 1, then that indicates that the lung is overinflated. Therefore, the peak inspiratory pressure should be reduced. So you should see this C20/C ratio on your ventilator. The DCO2, this is also called as the alveolar ventilation. The DCO2 is calculated by square root of tidal volume into the frequency. This is mainly useful in HFOV rather than in our regular ventilation. The total breaths per minute, if it is with the flow sensor, each breath, mechanical and patient breath, is calculated and gives you the total breath. If there is no flow sensor, then the ventilator will calculate only the mechanical breath, and it cannot sense the patient breath. So when you see the breaths per minute, you should know whether you have put the flow sensor on or it is not there. Coming to congenital diaphragmatic hernia, I thought I will just add a slide on that. I will not be going into detail, maybe because it's a chapter by itself. So what is very important for us to see here is, generally we feel that, we all know that the congenital diaphragmatic hernias will have hypoplastic lungs. We need to be very careful with those hypoplastic lungs. We need to use less pressure. We should be very gentle with them. So naturally our mind thinks that high frequency may be the ideal mode of ventilation in these babies. But contrary to our thoughts, we have found in a randomized clinical trial, which is called as the VICI trial, which has been reported in 2016, where they have found that, this is probably the first large randomized controls trial, where they found that the regular conventional mandatory continuous mandatory ventilation is favorable than your HFOV or high frequency ventilation. This is something which we all have to realize, that we don't have to rush to high frequency when we see a congenital diaphragmatic hernia. So I would also suggest for all of you, because I don't have sufficient time to cover this, all of you to just have a read on this ventilation modalities in infants with congenital diaphragmatic hernia. It is very interesting and is a real eye opener. So these are the recommendations given by the European consortium and the American group regarding managing the CDH. The only difference I found here was that the European group advised a very high pressure of around 28 centimeters to begin with, whereas the American group recommend around 25 centimeters. The rest of them, they remain almost the same. And anyway, this is available in the same article which I suggested already, so you can just have a read of it. Now, coming to the development of ventilation protocol, how important is this? And why do you need a protocol in a unit? When you're working in a unit, you have the neonatal physicians or the fellows or the registrars, whoever is working with you, they come from varied, different experience, or they may be more accustomed to different ventilators or different modes of ventilator. So as we say that neonatal units cannot be run by one person, you have different people coming in at different times. So babies on ventilator. So every person who comes in new for his shift makes his own changes. His liking may be different. Suppose you like pressure support ventilation, he may like SIPPV. So the change keeps happening, and in the bargain, the ventilation will not be uniform. So that is the reason you need to have a ventilation protocol in all the neonatal units. Before you start the start working on this protocol, make sure that your entire team is ready to accept that. Sit and discuss with them the guidelines and the protocols, what is the scientific evidence, why you are recommending the particular type of ventilation protocol. The proposed ventilation protocol should have the respiratory support, use of non-invasive support, criteria for intubation, surfactant administration, specific ventilation modes, which to use initially, which to use for weaning, when to change. So it should be in detail, protocol should be made. The usual range of settings, escalating the therapy to high frequency, indication to go for high frequency, weaning protocols, extubation criteria, and post-extubation management. Apart from that, so in specific conditions like CDH or mechanism aspiration or PPHN or BPD, what are the specific guidelines in these conditions? Even that should be included in the ventilation protocol. So these are the indications to go for high frequency ventilation. I'm sure most of you will be knowing. If the pressure is going above 25 to 28 centimeters of water, especially in smaller babies, significant early. So what for uncomplicated RDS, both jet and oscillator ventilation may be used. HFE is also indicated in infants with congenital diaphragmatic hernia, pulmonary hypoplasia, severe abdominal distension, and poor chest wall compliance. This congenital diaphragmatic hernia, what I mentioned here, this is not the first preference. The HFE is not the first preference. Maybe it may be suggested if your conventional ventilation fails, then maybe you may be suggested to go for high frequency. Extubation, mechanical ventilation protocol should incorporate extubation guidelines, when to extubate a baby. Generally, if the FiO2 is less than 0.35, PCO2 less than 50, and a MAP of 7 to 8, with a consistent spontaneous respiratory effort without excessive work of breathing, means that baby can come out of the ventilator. Post-extubation, you can CPAP is the most appropriate. HHFNC is not found to be very effective. If you are extubating very small preterms, less than 700 grams or less than 800 grams, in those babies, maybe NIPPV may be one of the better modes to extubate them rather than directly putting them on CPAP. The use of dexamethasone has always been controversial, but whenever you have an edema, you can always discuss with the parents and use the dexamethasone. The chances of extubation failure should always be discussed with the team members and the family, and especially, this is just a something which we follow is, as long as possible, try to avoid extubation overnight until unless it's really required, or if the baby is really doing well, then you can extubate. But it is always What I mean by this is extubation also should be planned rather than it being unplanned and taking the extubation, I mean, extubating the baby whenever you feel like, because at times we have found that when it is done, when there is less senior staff or less experienced staff, re-intubation becomes a big issue. Practice points. The volume targeted ventilation is the standard method of ventilating preterm babies. I think I have given sufficient emphasis for this by now. There's no difference in short-term outcomes to discharge between volume control and volume guarantee. That's what I meant. All those volume, the modes of different volumes don't get perturbed or disturbed by those things, because ultimately all of them do the same job. Synchronizing ventilation with baby spontaneous breath should be attempted always. Synchronized ventilation is the way to go. Number of terminologies in use for ventilation makes you more confused. So please know your ventilator well, which will help you to avoid this confusion. Conclusion: the baby is sick with minimal respiratory effort. Use these modes: IMV, SIMV, SIPPV with volume targeting. SIPPV with volume guarantee, helpful for all preterm and term infants. Pressure support ventilation, good choice for well neonates or those with good respiratory drive who need time on the ventilator. For these people, pressure support ventilation will be a good option. This is an interesting article. I've just put it as the reason why I've put it is, if you look up, you'll see that there are not many randomized trials, and you don't get the kind of support you get for if you want to do any trials on these ventilator modes. And also, whenever a new ventilator comes with a new mode, without even verifying the facts or without even knowing whether it is really helpful or not, we all adapt to that. Now, why is that happening? That is mainly because the ventilator companies are not sponsoring these. Neither are we taking the new options. An study which has been reported in the Lancet Respiratory Medicine, where they have gone through last 2 decades, various types of respiratory supports have been introduced. And when they saw that, very important thing what they found is, they looked into 5 years data. They have seen that most of the trial which were supported by the local institution, the public support was only 11%, private support was 43%, 46% had no support, no institutional support or any sort of support. In fact, they found that charities provided most of the private funding and the small minority benefited from a public grant. So this shows that there is a huge vacuum in this area where you need to have more papers, more randomized control trials for this, I mean, to know which mode is better than the other or to recommend any particular mode. Thank you. I think I've covered most of it. So if I have the permission, can I play the video, Prashant?
Please go ahead, sir. Please go ahead, sir.
Everybody, I'm just going to do a demonstration on SLE 5000 ventilator.
Sir, video is not seen. Just take away the
to begin with,
presentation.
first let us see what
Cancel the presentation.
that ventilator has got to offer. Basically, you should never get intimidated by these ventilators.
Or minimize the, or cancel the presentation. Stop sharing presentation.
You should know
Stop sharing the presentation and cancel.
Okay, okay, fine.
Then we will be able to do the video.
Now the modes we have is, we have the CMV mode, the post pressure support ventilation. The PTV mode here, what we call as PTV here, it is the assist, synonymous with the assist control or with the SIPPV. SIMV, as you know, it is synchronized intermittent.
Now you share screen
and HFO with CMV or high frequency only. These are all the modes which are available on this ventilator. Now this is another mode here called as standby. This standby mode is
start from the beginning.
when you are doing suctioning for the baby. And everybody, I'm just going to do a demonstration on SLE 5000 ventilator, which we use in our unit. And to begin with, first let us see what are all the modes that ventilator has got to offer. Basically, you should never get intimidated by these ventilators because they only do what we ask them to do. And we should know to control them, and we should have the knowledge of what they are capable of. Then it becomes easier to use them. For all the modes we have. Now the modes we have is, we have the CMV mode, there is the post pressure support ventilation. The PTV mode here, what we call as PTV here, it is the assist, synonymous with the assist control or with the SIPV. SIMV, as you know, it is synchronized intermittent mandatory ventilation. And HFO with CMV or high frequency only. These are all the modes which are available on this ventilator. Now this is another mode here called as standby. This standby mode is especially useful when you are doing suctioning for the baby, and more so when the baby is on high frequency ventilator, because that avoids the baby getting and avoids the de-recruitment of the lung, and it becomes easier to continue with the ventilation after the suction. Now the other mode where we have ventilation off is a mode which you can use to set the ventilation. Now to begin with, let us go to SIPPV or the patient required ventilation. As you see, now I have connected this to a test lung, so it's not on a baby. So what we need to do is, first oxygen, you can keep it at 75 or 80, and then peak inspiratory pressure, and keep it at about 26. Peak, and keep it at around 5. Inspiratory time is at 40, and backup I'm going to keep at 40. Ventilation. Now, this patient triggering happens mainly because of this. What you see here is the flow sensor. This is the one which will sense the baby breathing and will alert the ventilator to give a breath. Now in SIPPV, what happens is, suppose the baby breathes 60 times, all the breaths will be assisted by the ventilator. Now for that to happen, one very important thing you need to do is the trigger. So if you don't set the trigger at the ideal level, then the baby will not trigger the breaths and it will not get the adequate trigger breaths. So what you're seeing in brown, this is the level where the triggering is, it is around 0.6. Now, generally what they say is, if you keep it at around 1 or above, the triggering will not happen and you will not see the baby triggering the breath. So ideally, you should keep it at around 0.6, 0.4 to 0.6, where the trigger sensitivity will be very high. How do you know the baby is triggering? Now that you will know by, for example, now if you are giving this, the orange wave, what you are seeing here, I'm trying it on the test one. Yeah, this orange wave, what you are seeing, that is the patient breath. That will be shown, the dip, and followed by the orange wave, that is showing the patient, that shows that the patient is triggering. So you have set the peak and the inspiratory time and the breaths per minute. This breaths per minute is set up as a backup rate. Now, suppose the same if we go to SIMV. Now, when we go to SIMV, what happens is, now the triggering, everything remains the same. Your pressure also, setting the triggering also remains the same. Only difference in SIMV is the baby will get only the set number of breaths as assisted breaths. Now suppose you have kept it as 60 assisted breaths, the baby will get only only 60 assisted breaths and not more than that. And even if the baby is breathing more than that, they will all be unassisted breaths. Apart from that, the triggering remains the same at 0.6. The rest of the settings will remain the same. The next mode which you have to see is the pressure support ventilation. Now, what is the main difference in pressure support ventilation? In the pressure support ventilation, what happens is the baby will set its own inspiratory time. So the inspiratory time, even though you have to set the peak, you have to set the peak, you have to set the backup rate, but the inspiratory time will be set on its own, and even this is only a backup rate because all the breaths will be assisted. Now the inspiratory time, to know whether the baby is setting its own inspiratory time, what you have to see is you have the set that is 0.4, and what you see here is the inside that will be the actual inspiratory time which the baby is breathing in. So this pressure support ventilation, that is also called as flow interrupter. So these are flow interrupter ventilators where when the baby is breathing, in other modes, if the baby wants to breathe out when the ventilator is giving a breath, the baby will not be able to do against that breath. Whereas if it is on a pressure support ventilation, if the baby wants to breathe out even when the ventilator is giving a breath, the ventilator will sense that the baby wants to breathe and it will interrupt the flow at that level. That's why it is called as the flow terminator or the flow interrupter. The pressure being given will be stopped and it will allow the baby to breathe. So because of that, and also as the baby is allowed to breathe as many times as possible, this mode is found to be very physiological and very gentle for the babies, especially when they require long-term ventilation. Now, once we are doing this patient-triggered ventilation, suppose you want to add a volume. So, in that time, what you need to do is you go to the targeted tidal volume. So, press that. So, immediately, on the screen, you'll get one more parameter called as the tidal volume. Now, this tidal volume you can set as around 4 ml per kg. So, suppose you want to keep it at around 8, or say I will keep it around 6. So, once we keep that, the ventilator will make sure that every breath, it makes sure that the tidal volume of 6 is achieved during every breath. That it is able to do because by assessing the volume during the expiration, the ventilator will sense what is the amount of pressure it has to deliver to achieve that tidal volume. For that reason, what you see here outside the curve is what we have set, that is at 25, but the baby is getting only 12. The reason is the ventilator has sensed that to achieve this tidal volume of what you have set at 6, it is enough to give a pressure of 12. So this is the indication that the baby is getting sufficient volume. So the ventilator will see to that the baby gets the set number of volume. The same type of volume guarantee can be set with the SIMD mode and with the pressure support ventilation. Apart from that, one thing which is very important, what we usually know is, when we are driving a car, as we see the dashboard, we should be seeing the dashboard of the ventilator. The parameters which are given here are very important for you to manage the ventilation. Generally, we try to manage ventilation by only depending on the blood gas. But here, using this also you can manage. One of the things what we get here is the trigger, so you will know how many breaths the baby has triggered, the total number of breaths per minute, and inspiratory time which is kept, and you have the tidal volume, which they usually, if there is a gross deterioration in the tidal volume, that means there may be a tube block or even a dislodgement of the tube, which causes the drastic reduction in the tidal volume. The minute volume is equally important. The most important is the leak, because especially when you are doing volume guarantee ventilation or targeted tidal volume ventilation, it is very important to have the leak below 20%. Because even though these ventilators are geared to overcome a leak of 50%, generally you will not be able to give effective tidal volume if the leak is around 50%. Generally, what is recommended is, if it is above 20%, better to re-intubate and with a bigger size tube and continue with the volume guarantee ventilation or the targeted tidal volume ventilation. The next one is the resistance. In this resistance, whenever you see a value of 300 and above, that means there is acute block of the ET tube, or it could be kinking of the ET tube, or it could be worsening of the bronchopulmonary disease, or it could be worsening of the MS. So always look at the resistance. Anything above 300, it should alert you. The other one is C20 bar C. That means when you go for the C20 bar C, generally what happens is, it will measure 20% of the last breath and it will calculate the compress. Suppose the C20 bar C is less than 1. Now here you are seeing it as 0.7. That means the compress, the over distension is occurring and hyperinflation of the lung is there. So you need to reduce the pressure. So that is the importance of the C20 bar C. And next is the mean airway pressure, which helps us to know what's the, especially when you want to improve the oxygenation, you can use this to improve the oxygenation.
Sir,
Apart from that,
sir, Aras sir?
Yeah, it is just few minutes.
Few more minutes, sir.
I'm not going to deal much with the graphs because there's a separate session on that, which is the other ventilator which we use. I think this is a very common ventilator which is available in most of the units. Apart from that, if you want to take the, you have the ventilator set on SIPPV with volume guarantee. The similar method can be employed to use the volume variation, but at the end of the day, they always deliver whatever is the volume guarantee. It's only the technique which is different, but ultimately both of them effectively deliver the volume. So this is about the practical demonstration for the conventional ventilation with patient triggering and volume ventilation in either of these ventilators.
I think I'm done with that. Should I close it?
Yes, sir. Yes, sir. You can stop sharing the screen.
Okay.
Yeah. I think Dr. Ashwini was having a little problem in connecting because the internet had gone. Sir, I request Dr. Dinakar, sir. Dr. Dinakar, sir. Yeah. We can start the discussion in case if Dr. Ashwini is taking some time to join back. So today's session will be moderated by Dr. Dinakar. Dinakar, sir.
Hello?
Hello.
Hello, Prashantha. Dr. Prashant.
Sorry. Hello, sir. Few
Dr.
questions.
Prashant.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. Sir, Dr. Ashwini is taking time to join back
No,
because
do
she just.
you?
So questions are forwarded to you
Yeah.
from Facebook and YouTube and other thing to you. There are around
1 minute,
around
1 minute. Hold on. One nimsha. From Facebook, I can see. From this thing, I can see the questions.
Yes, sir.
Okay, then can I start asking the questions?
Yes, sir. Yes, sir. Please start the discussion, sir. Once Dr. Ashwini joins back, we will start her session as well. Please start the session, sir.
Oh, 1 second. Hold on. Just because I thought, okay. Chinu, wait. Chinu, don't make noise. Okay, I'll start. 1 second here. Please hold on. I am taking. Yeah. So, what is it? 1 second. Sir, it is first question is from Assam. Dr. Prashant?
Yes,
Yeah.
sir. Yes, sir.
No. Prashant URS, please.
Yes, I can hear.
Yeah, please. This is from Gunjan from Assam.
Okay.
Okay, Gunjan from Assam. Yes. When I start volume guarantee with SIMV, I am using VN500. We get alarm oftenly. Low tidal volume alarm will come oftenly, and respiratory rate high alarm comes oftenly. What to do, sir?
Dr. Gunjan, see, there's a trick for your low tidal volume alarm. What you need to do is when you are setting that alarms, you make sure that for low tidal volume, you set at least 3 ml more than what you have set. Okay,
Yes,
so
sir.
suppose if you have set a tidal volume of around 6 ml, your alarm should be at 9 ml. Then this inadvertent low tidal volume alarms will not come. For the rate also, similarly, you need to check your ventilator book, and there will be some ventilator manual which will give you where to set the alarm, because these alarms depends on how you set them, only then they will beep. If in spite of setting as per your manual, if you are still getting a alarm, please call your biomedical person. There must be something wrong with your ventilator. But the low tidal volume alarm can be avoided by setting 3 ml above the set tidal volume, whatever you have set.
Yeah.
Does that answer your question?
Yes. Dr. Prashant URS, can I add some more thing if you don't mind?
Sure.
For the Gunjan, if you don't mind.
Sure.
Okay. Okay. Low tidal volume, because I am downloading the questions. That is the reason I am sorry. That is the reason I am adding. Okay, because there are so many questions are there for you. You have to answer. There are till now 13 questions I am seeing. Sorry. Okay. Low tidal volume, whenever you switch on the volume guarantee in VN500 or SLE 6000 and our Acutronic Fabiana, what we are using that machine. If it is coming, first thing I'll check 3E, because usually I teach my postgraduate 3 ETT, means ETT obstruction. ETT obstruction means block, then ETT leak or ETT displacement, because it is not coming back, or air leak. This first thing I will check: ETT obstruction, ETT block, block, ETT displacement, ETT leak or air leak. This is the things I will check first thing. And as sir told, Prashant URS sir told, so we have to increase the PIP little higher side. PIP, that PIP limit you are going to adjust. That whatever you are adjusted, because 3 to 5 only max to max you can adjust. So go little further higher. If you are adjusting to 15, go to 20. If it is 20, 25 max, that is the way you are going to do it. Then another one is usually water is condensed. That one you think. What he asked, another one is do, sir. RR alarm is coming very high. What should I do? He is using VN500, same thing, sir. Ventilator, ventilator.
No, see, as you told, Dinakar, the tidal volume, what I suggested to him, that troubleshooting is correct when you get a low tidal volume, but his problem was inadvertent alarm. So if it is an inadvertent alarm, it depends on what alarm threshold you have set. But I do agree, the other things also have to be seen.
Yeah.
And the VN500, to be honest, I am not very well versed with that ventilator. Okay.
Yeah.
So we don't have it, and though we use the dragger, we don't encounter those problems with our regular dragger Babylon. But VN500, I have no idea. Let me accept that.
Suppose if, sir, Gunjan sir, I don't know what is your age, but however, sir, I am calling you, please, respect-wise. The one more thing, please, if the RR alarm is coming very high, first think the same thing, water logged in the tube that moves by the machine, any machine. So same ETT leak. Then one thing with all those things, once you corrected, if still it is coming, trigger you should just increase from whatever the -1, 1, 2, whatever it is there, auto triggering this thing. So one is over. The second thing.
Sir, Dr. Ashwini is ready. Shall we continue the session discussion later? Is it okay? Dr. Ashwini?
It's up to you, Prashant. You are the big boss.
No.
Prashant, you ask Prashant, is it okay?
Yeah, fine with me.
Okay, sir. We'll just start the session. Hello, Dr. Ashwini.
Hello, sir. Yes, sir.
Please start sharing the screen.
Yes, sir.
We have Dr. Ashwini. She's a consultant pediatrician neonatologist at Ashraya Neonatal Hospital, Chikmagalur. And she's a well-renowned neonatologist in our fraternity. And it's our privilege to have you, Dr. Ashwini.
Thank you, sir.
For joining and accepting our request to be a part as a speaker to the Karnataka chapter. Over to you. Please start the session.
Thank you, sir. So am I audible?
Yes. Clearly audible.
Okay. Good evening, everyone. It's an immense pleasure talking on this platform. And the topic I've got today is deterioration of neonates on ventilator and humidification significance. So, approach to deterioration on a ventilator. As we all can see that intensive care unit is associated with adverse outcomes, which is independent of the underlying disease. So some of these, the origin of these may be silent, like example, hypocapnia and hyperoxia due to excess ventilatory supports, or hypoxia secondary to a blocked endotracheal tube. How can we, know how to approach the deterioration on a ventilator is by awareness strategy, that is anticipation, and then a rapid information synthesis, assessment manuals, analysis and diagnosis. The majority of deterioration events are either, like most of us, what we see is usually respiratory or cardiorespiratory, desaturations, bradycardia, and then they go into other features such as pallor, hypotension, bradycardia, or seizures. So we can know about the deterioration based on the bold PEEP approach to deterioration on ventilator. So I'm going to go by the letters one by one. So B first stands for bad or worsening lung disease. Okay, so there are 7 bifurcations I've made to know what is the history, examination findings, charts, blood gas, pulmonary graphics, X-ray and actions, what is to be done in each of this, so that it's very easy to take a take-home message. Okay, so in a bad or worsening lung disease, usually in a history, what do we get? There is no antenatal steroids, there is PPROing, there's a high FiO2, and whether we have to see if we have weaned the baby too quickly, and there is blood up the ET. So on examination, what can we notice is a poor chest movement, a reduced air entry bilaterally, and a negative cold light. Charts will show a rising FiO2 requirement, desaturations, and a poor handling of the baby. Blood gases will show a respiratory acidosis. Pulmonary graphics will show a low compliance and high resistance, blunted flows, and a flat volume pressure loops, low minute ventilation and tidal volume, and there might be a possible leak too. X-ray shows a bad RDS, a low volume lungs, and of course consolidations in some of the X-rays. So what are the actions we can do for this? Like, you know, if we find that it's a bad or a worsening lung disease, it usually responds to an increasing PIP, MAP, and then surfactant therapy, and also by taking care of the pulmonary hemorrhage. Next, in the bold peak comes our obstructed ETT. History-wise, there is secretions, sepsis, blood up the ETT, and variable FiO2. On examination, we can find that there is variable chest movements, there is reduced air entry, crepitations, and V's. On charts, we can see again that there is a rising FiO2, desaturations, poor handling, and frequent suctions. A blood gas can show respiratory acidosis, mixed acidosis in pulmonary hemorrhage. And pulmonary graphics will show variable resistance and compliance, a variable flow, and often it is blunted too. X-ray shows variable or non-specific changes in case of an obstructed ETT. Actions, it usually improves on suctioning, may require a new ETT if completely blocked. Increasing PIP briefly may overcome the secretions at the tip of the ETT. The L stands for long ETT, and history-wise never settled on a ventilator. Long ETT on an X-ray and dental rolls may be in use. Examination-wise, is a poor chest movement, and the air entry most of the times is usually seen on the more on the right side and very less on the left side. The air entry usually always improves with pulling out of the ETT. The charts again show rising FiO2, desaturations, and poor handling. Blood gases may show respiratory acidosis. The pulmonary graphics will show high resistance and blunted flows. X-ray can show a long ETT, asymmetry, right side hyperinflation, and right upper on the right upper lobe. Actions, what we can do is pull back the ETT and observe the response. You may need to increase the PIP to inflate the left side for some time. Plan re-intubation and after pulling out ETT back and recruiting the deflated lung areas. This is very important because first you need to let the lung recruit, and then after that plan for a new re-intubation. So D stands for a displaced ETT. Sudden desaturations on history, no response to TP's ventilation or increasing FiO2 and PIP. There is no chest movements or air entry, audible leak, no color change with EtCO2 sensors. So charts will previously show that the child was stable. Recent handling must have been done. Poorly sedated baby and very active if the child is, then we can see a displaced ETT. A blood gas will show previously stable child, and pulmonary graphics, no expiratory flow, incomplete loops, and minute volume and tidal volume alarms are seen. X-ray will show ETT seen to the right of the trachea or the left of the NGT. Actions, consider blocked ETT, try increasing the FiO2, PIP, and TP's ventilation, and suction, remove the ETT and replace. Again, P stands for pneumothorax. History-wise, there is no antenatal steroids, moderate to severe RDS or hypoplasia, delayed or poor early care, including late surfactant, high PIP, and drop in the BP. Asymmetry of chest shape and movement and air entry. Positive transillumination can be seen on examination. Sudden change or deterioration can be seen on the charts. Blood gas will show a worsening respiratory acidosis. Look for leak in the volume pressure loops and also the VT, waveform high percentage leak. Leak may be minimal or variable with stiff lungs. So X-ray will show definite pneumothorax, tension pneumothorax, and transillumination will be positive, and needle if unstable or tension identified. If there is a tension identified, then place an ICD as soon as possible. So E again stands for equipment failure. History wise, it will show frequent alarms, frequent water in the circuits, ventilator cutting out, unexplained hypotension or hypoglycemia. There will be a poor chest movement and air entry, improves with TPs on same settings. In the charts, nurse may indicate concerns over the ventilator, and even in the blood gas, it will be a previously stable blood gas. Pulmonary graphics may show obstructive pattern if the water in circuit. Interference in the time flow waveform can be seen. X-ray not necessary for minor ventilator problems, but always check central lines are not in the heart and are not misplaced. Actions: look for leaks or obstructions in the circuit, review the alarm settings, clear water from the circuit, ensure flow sensor is vertical and not soil, manage the line positions. EP lastly stands for equipment patient asynchrony. So in history wise, it can be an old bronchopulmonary dysplasia baby, bad lung disease, a long ETT, recently reduced or stopped morphine or etracurium, and there is hyperinflation. On examination, you can find active baby, variable chest movements and chest splinting and hyperinflation. Charts, there can be desaturations, pain score, high heart rate, blood pressure rising high, and FiO2, high FiO2. So blood gas will be variable. Pulmonary graphics, normal to high resistance, and periods of no flow with splinting. Beaking of on the volume pressure loops are seen. X-ray is significant of BPD. Recent worsening hyperinflation, squeezed heart can be seen. Actions you can see: confirm the tube patency and the length, optimize the mode and the trigger, consider paralysis and usually extubation if otherwise the baby is stable, and normalize the lung volume. So after I complete all the bold peep approach to deterioration on ventilation, I would want to talk on the approach to ventilator alarms. So these are day-to-day very important, and most of us sometimes tend to neglect them. And how important are they, and what are the certain important alarms, and what action is to be done, I'll be showing in the further slides. So mainly, you know that the ventilator alarms are to alert the healthcare professionals to unexpected changes in the ventilator, example disconnections or a dislodged tube. Color and sound coding of alarms highlights the relative urgency. So things like, you know, never set a low limit for of minute ventilation, and all those things are very basic. A pragmatic approach for ventilator alarm should include: review the patient with nurse and ask for help if required, check for chest movement and air entry, review bedside monitoring including saturations, heart rate, etc. Does the baby need resuscitation? You need to check, and review the ventilator current trend data and blood gases for key parameters and pattern recognition. So approach to ventilator alarms: if there is a low minute volume, possible common causes can be a disconnection, new ventilator circuit leak, lack of respiratory drive with inappropriate mode, worsening lung disease, and a blocked tube and splinting. So approach should be that you review the patient, auscultate both the lungs, check ventilator circuits, ventilator settings, modes, and pulmonary graphics, and consider a TP's ventilation. High minute volume tells us that it is an incorrect weight entered, change in the lung compliance, inappropriate mode or rate, or there is auto triggering. So again, review the patient, auscultate both the lungs, review mode of ventilation, backup rate, check flow sensor, and remove water from the ventilator circuits. So set tidal volume is not reached. Inappropriately low Pmax, worsening lung disease could be one of the causes. Significant leaks, inadequate PEEP, and atelectasis. These are the common causes which we can see in them, and approaches can be: review the patient again, auscultate both lungs, check ventilator settings and limits, lung recruitment, pulmonary graphics, and consider chest X-ray. Flow sensor alarms: condensation of water in the flow sensor, and there could be a mechanical failure. So approaches should be: keep the flow sensor in an upright position, recalibrate the flow sensor, and consider changing the flow sensor. So respiratory rate high, what could be the possible causes are: the falls triggering by water in the ventilatory circuit, high backup rate, and there could be seizures. Approaches are: review the patient and auscultate both lungs, review breathing circuit and the ventilator circuit, and check the trigger settings. Apneas, it could be because of dislodged, obstructed tube or splinting. Again, see the patient and auscultate both the lungs, ask for help, review the mode of ventilation and the ventilator settings. So these are the important things I spoke about: worsening of the baby on the ventilator, and also about the ventilator alarms. Coming to my next part of the topic is significance of humidification. So why do we all need to humidify the air which is reaching the baby? So during intubation and ventilation, it is essential that you optimally heat and humidify the air. So failure to achieve will lead to long-term damage, including bronchopulmonary dysplasia, and it can cause damage to the upper and as well as the peripheral airways. So what is the significance of humidification is, when intubated, first of all, the upper airway, which heats and humidifies the air to the core body temperature and 100% relative humidity, is always bypassed. So the upper airway is very important in heating, regulating the heat and humidity of the inspired and the expired gas. So during inspiration, what this upper airway does is it heats and humidifies the air which is going in, and then after that, this reaches the this reaches the trachea and of course and the lungs, and heat and humidity is transferred back during the expiration from the moist and warm alveolar gases to the mucosa, thereby preparing its use for the next cycle. So this is how it works when we normally breathe in and breathe out, and our upper airway plays a very important role in controlling the heat and humidity of the air which is breathed in and breathed out also. So moisture and heat are added or removed from the respiratory and expiratory gases by evaporation, condensation and convention. So what can suboptimal conditioning of inspired gases to the airway? So during both conventional and high frequency ventilation, the gases entering are very low in temperature as well as the humidity. The longer the respiratory system is exposed to suboptimal heat and humidity, more likelihood that they can have a long-term damage. So this will also affect this will mainly affect the mucociliary transport velocity. So in preterm babies, what happens is, apart from the airway, even the alveoli are immature. So, and even both including the type 1 and type 2 cells. So further, the heating and humidifying is further affected when we bypass the upper airways and we are trying to ventilate the preterms. We should be more careful, and we should be always, it should be in our back of mind that even the alveoli are not ventilated. I mean, alveoli are not well developed. So they can have issues with heating and humidifying the air which we are giving in. So in preterms, the damage may be more rapid and may be greater, and long-term sequences such as bronchopulmonary dysplasias are very commonly seen. So low heat and humidity delivered to the upper airway and respiratory tract, it causes flattening of the normal tracheal mucosa. It replaces the epithelial cells by non-ciliated epidermoid squamous metaplastic cells and exposed openings of the submucosal glands. So the submucosal glands are the ones which secrete the mucosa. So the submucosal glands are also damaged, and the mucus production is reduced, and hence the airways get dry. Excess heat and humidity results in condensation of water. Achieving the optimum heat and humidity, situations of low or inadequate heat and humidity delivered to the respiratory tract may arise whenever assisted ventilation, that could be an invasive or a non-invasive, is initiated. This may be at birth, during delivery, and also during resuscitation. It starts from there, where we should take care of humidification as well as heating. So this is a picture which is showing what happens when there is optimal humidity. When there is low heat and humidity, it mainly causes increased mucosal viscosity. It causes reduced mucociliary transport. It causes inflammation and cell damage, atelectasia, and shunting. So what happens when high heat and humidity occurs is, there is condensation, reduced mucous viscosity, dilution of surfactant, hypotonic challenge and thermal injury, and there is also a cell damage. So you can see that there is the difference in the pictures, where there is damage to the vocal cords and the trachea from the ETT also, and beyond the carina, and there is erosion and dissolution of the epithelial cells with the mucus strands. So clinical situations with suboptimum conditions also we should consider, like ambient air conditions. For example, if air outside is warmer, so what does the humidifier do is that the humidifier produces less temperature to compensate. So then the humidification reduces, and hence it can lead to further issues. Location of the distal airway temperature probe is also important. This is most commonly seen when in a radiant warmer the baby is there, or in an incubator the baby is there, and the distal airway temperature probe is exposed to the false temperature. So because of that, the humidifier again reduces the temperature, and hence the humidification also reduces, and these children are more prone to cold stress because there is false reduction of the temperature because of the false detection of the heat when the distal airway temperature probe is kept inside the radiant warmer or in contact with increased temperature. So we should also make sure that during resuscitation, transport, changing ventilator circuits and setting up of ventilator equipments and circuit, we should concentrate on heating and humidifying the air. So mainly what happens with heat and humidification is, if there is low temperature and a high humidity, edema, ventilator associated pneumonia. So high temperature and high humidity, it can lead to high thermal damage to the cells, water condensation, watery cupus secretions, surfactant dilution, reduced mucociliary transport, interstitial edema, and a ventilator associated pneumonia. So low temperature, low humidity can cause hypothermia, again sticky secretions, inflammation and cell damage, mucus plugs in the core, squamous metaplasia, atelectasis, and reduced surfactant activity. And a high temperature and low humidity can cause thermal damage to the cells, thick sticky secretions, inflammation, mucus plugs, and in the peripheral airway, squamous metaplasia, atelectasis, gas trapping, and reduced surfactant activity. So while humidification, what happens is that the heated section, what you can see, usually the temperature, what is the optimum temperature we need is 37 degrees, which will lead to the humidification of 44 milligram H2O per liter. So in the heated section, usually you expect that the temperature is almost 3 or 4 degrees more, and in the unheated section, where there is endotracheal tube and before it reaches the lungs, the temperature again comes down to 37 degrees Celsius. So that's how it works. So initially the temperature is more in the heated section, and in the unheated section it comes down to the temperature which is required. So there are different types of ventilator modes, like high frequency ventilation and conventional ventilation. So there are different kinds of damage which can happen with different kinds of ventilation also. If this damage continues in prolonged ventilation regardless of the initial cause of the damage, then metaplasia of the upper airway and fibrosis of the peripheral airway may be the outcome, and that is essentially lead to BPD. In high frequency oscillation, increased inspiratory flow will produce increased inspired temperature but decreased humidity delivered. As well, amplitude also has an effect on the inspired humidity. The higher the amplitude, the lower the inspired humidity, while oscillation frequency has less effect on the inspired humidity. So this is a picture which is showing differences in the damage to the upper airways as well as the this thing in the conventional and the conventional and the high frequency ventilation, which ultimately due to prolonged chronic changes it will lead to BPD with squamous metaplasia and the fibrosis of the peripheral airways with mucus plugging in the upper airways. So humidification in non-invasive ventilation is also important because we cannot think that because non-invasive is not putting an ETT and the upper airway is is there. So we cannot think that heating and humidification is not important. Heat and humidification is not important in non-invasive ventilation. It is very important because medical gases what we use are very cold and dry, and so hence even in CPAP and HFNC it is very important to heat and humidify the air which we are delivering to the respiratory tract. So, and CPAP now, because it's gaining a lot of importance because of surfactant delivery method like Ensure or Mist, and even HFNC because it is gaining a lot of popularity in newborns now. Care should be taken to even check about the heat and humidification in non-invasive ventilation as well. So achieving optimum humidity. So our recommendations, of course, the UK and US recommendations are different, but we have it that we have to reach 44 milligram H2O per liter gas. So temperature, the recommendation is 37 degrees Celsius at the distal airway temperature probe. And optimal heat and humidification of the inspired gases is essential during intubation and ventilation. Many factors contribute to the conditioning of the inspired gases, which I mentioned previously. That is the ventilator type, ventilator mode, ventilator settings, the humidifier types, humidifier settings as well. Thus, we have to look into all these and make sure that the inspired air is well humidified and heated. So coming to conclusions, do's and don'ts in humidification. The summary: the ventilator circuit must be changed at least once per week. The humidifier system must be inspected at least once a shift, that is 3 times a day. And the adequacy of water level in the chamber, the presence of condensate in the circuit, all this must be checked. Overheating can lead to cascade of effects beginning with mucosal heating. Overhumidification can lead to increased secretions and hypoxemia. Excess condensation in the circuit indicates inappropriate humidifier settings. Unlike the vapor associated with delivery of the heat and humidity into the airways, the condensate may be contaminated by bacterial colonization and may lead to VAP. The humidifier chamber and circuits must always be below the ETT height. This is very important. This will prevent any condensate from inadvertently flowing into airways, which can be catastrophic. If the condensate is difficult to manage, the use of water traps in the inspiratory and expiratory limbs may be considered. Coming to summary on deterioration on ventilator. So whenever there is acute deterioration and bradycardia, please do a bedside assessment, history from bedside team, examination, trend data on monitor, pulmonary graphics, blood gas and chest x-ray review. Go through the bowl peep approach and bedside actions such as suction the ETT, adjust the ETT, increase the PIP, and trans-elimination should always be done. New blood gas should be taken and a chest x-ray. So diagnose and manage the specific respiratory event, open the airway and adjust or replace the ETT, open lungs and normalize the PaCO2. So acute non-respiratory events such as sepsis, hypotension, acute anemia, blood loss, profound metabolic acidosis, acute abdomen, seizures must also be considered, and they should be kept in mind and they should be acted upon accordingly. And an abdominal x-ray, cranial USG, echo, a septic screen, lactates, fasting blood, clotting, and an EEG should be done. And manage and specify specific non-respiratory event, the like volume replacement and then transfusions and antibiotics, and then stabilize the baby on the ventilator. So this is the algorithm approach to any child which is deteriorating on the ventilator, so that we don't miss out anything when a child is deteriorating on a ventilator suddenly. Thank you.
Yeah. Thank you very much, Dr. Ashwini. So we will move on to the discussion part. It was a wonderful presentation. Yeah. So I want
Prashanth?
Sir?
Yeah.
Yeah. So just 1 second.
Prashanth?
Yes, sir. Yes,
Prashanth,
yes, sir.
can I go ahead with the questions?
Yes, sir. Yes, sir. Yes, sir.
Yes. Ashwini, talk was very nice, very crisp, like Prashanth URS. Very, very determined what to do. You told very good. Thank you very much. You got till now only 3 questions. Sorry, we will wait. Okay. First, Prashant sir, can I go ahead, sir?
Yeah, please.
Sir, from Gaurav from UP, volume guarantee or volume target ventilation, is it same?
See, as I told in the talk, both of them do the same job. It is only the terminology is different. What we should understand is these ventilator companies, to avoid the patent, they come up with these different proprietary names. And technically how they do it, there may be a slight difference. But here in volume guarantee and patient triggered ventilation, both of them get the tidal volume at the expired tidal volume and determine the pressure for the next breath. So both of them, there is no difference in it.
Yes, sir. Hello? Prashant?
Yes, sir. Yes, sir. Please go ahead, sir.
Okay. Gaurav, I think so you heard. Next, other question from Karnataka, Mahadevappa. Other than chest X-ray, how can I detect I have got a optimum PEP? Dr. Prashant URS.
Optimal PEP, you mean?
PEEP. How to optimize? How, other than chest X-ray, is there any other method? I got an optimum PEP for this one.
Yeah, see, generally the PEEP what we keep is around 5 to 6. Now, when we are following the open lung strategy, we always advise to keep around 5 to 6. So once that is set at that level, that is the optimum PEEP what you would aim for. And if the PEEP is not delivered to that level, automatically you get an alarm. Did I answer the question?
No, is there any other method other than chest X-ray? How to decide this PEP is correct?
No, see, PEP is not the only one which decides about the volume of the, the volume which the baby is getting, or whether the baby is getting sufficient pressure. See, it is the MAP, the mean airway pressure is the one which is a combination of the PEEP and the PEEP. So now, generally you set the PEEP around 4 or 5, and then you adjust the PEEP. Generally, we don't go to handle the PEEP much. And especially now, after you have got the volume ventilation, and when you put them on volume guarantee, and when you put them, set the tidal volume, generally that much of tidal volume will be delivered. And if they are not delivering that tidal volume, then automatically you get the alarms. That's how you'll come to know.
Yes, sir. Okay, I think so. Gaurav, UP, understood. So one more question. It is from West Bengal. Binay. Why need more volume in extreme low birth weight?
See, the more volume in extreme low birth weight is this, the flow sensor, it will add around 1 ml of dead space. So as it is the ET tube and the others, they all add to the instrumental dead space. There is what is called as the instrumental dead space. So this flow sensor adds around 1 ml of dead space. In extreme preterm babies where the lung volumes are very small, you need to add this additional 1 ml just to counter that loss in that dead space.
Yes, sir. I think so. Another question is also same, like why in BPD you need high?
I didn't get that.
The same question. I think so. So. Both are from West Bengal only.
I can hear now. Tell me.
Yeah. Why we need higher once again volume in BPD, bronchopulmonary dysplasia or CLD babies? We do use higher lung volume. Why?
Yeah. See, in bronchopulmonary dysplasia, what happens is you have uneven alveolar ventilation, because of the lung condition, there's already lung damage and the alveoli will not be the same.
there will be patchy alveolar ventilation, because of which you'll have to keep a little bit higher volume rather than what you use in the general ventilation for RDS or what we call as even lungs.
Yeah. Dr. Prashant URS, can I add for that little more?
Yeah, please go ahead.
Yeah, I think so. Binay and both are, I think so, friends. They have asked from the West Bengal, same time. For the extreme low birth weight, what Prashant URS sir has told, it is correct. For this thing also, what is that BPD, chronic lung disease, we do use a higher lung because of two reasons. Number one, because usually acquired tracheal dilatation will be there. Acquired tracheal dilatation will be there to compensate that, number one. Number second thing, uneven VQ mismatch, because some places, as Dr. Prashant URS told, some places it is completely collapsed or abnormally developed. In some places it is overly distended, because BPD, you know that everybody know BPD definition, simple, 3 word: chronic, abnormally developed or mal-developed lung, then incomplete resolution of inflammation. Chronic, incomplete resolution of the inflammation, and abnormal development. These 3 things, somewhere whatever you give the volume, it will trap in some places. In some places, you don't get the volume. That is the reason in BPD. One is tracheal dilatation, another is this reason we give higher volume. Okay, sir, I will ask one question to Dr. Ashwini, then we will go to you, because you have a lot of questions. Sorry,
Okay,
hold on.
No worries.
So, Ashwini, are you ready?
Yes, sir.
Okay. So all are practical questions. This is from Vijayawada, Dr. Charan, AP. How to prevent micro sensor damage? Micro sensor or whatever the flow sensor, I think so, what he is telling. How to prevent micro sensor damage? Because we put a normal saline into our humidifier chamber. It usually, once the work is done, sometimes that normal saline, why it is damaging, he is asking. Any other way to prevent flow sensor damage, prevention of flow sensor damage?
So I
Ashwini.
think one thing is that by maintaining the temperatures, ambient temperature should be maintained so that the humidification is not more. And the microsensors can get damaged because of excess humidification also. And
Yes, Ashwini. Hello? Hello? Prashant?
Yes, sir. She's unmuted. You can talk, Dr. Ashwini.
yes.
Okay, Ashwini, please. Ashwini, can you hear? Can I ask Prashant URS?
Yeah, please.
Yeah. Wait, boss. There are so many questions. How to decide when to shift to higher modes? Okay, I think so. You have already told this, but from Rajasthan, Mahanti Jain, how to decide when to shift to higher modes of ventilator when I am using volume guarantee?
See, I think
you told already.
Yeah.
Please tell them.
Yeah. See, basically, when you have given the optimal tidal volume, what you have decided with the optimal pressure, and if you feel the blood gases are not improving, the compliance is not improving, and the baby is still requiring much higher rates, then or much higher pressure, then I think it is safer to move over to HFOV.
Yes, sir. So I think so. Mahant Jain, I think so. You understood. He has already told even in the class also. He has put a slide also. When the PIP is going more than 25 in a less than 1 kilo baby, if it is going more than 30 in a more than 32 weeker or more than 1 kilo baby, if PIP is needing persistently, constantly, that is the time with ABG, SpO2 is not able to manage, think of other modes of ventilation. That's what he already put it in the mode.
So just
Then we'll go to the other class. Please.
One more tip I'd like to add. See, one thing is the pressure we cannot tell exactly for. That's why I said the optimal pressure. When you are seeing when you are the clinician, you will be able to decide whether you reach the highest pressure possible on that particular baby. That is one thing. And second thing is always try to target the saturation to 88% to 93%. So with your optimal pressures and the volume, you are not able to target the saturation to 93%. And if it's still requiring more pressure, probably that may be the time when you have to think. And if your blood gas is showing very high PCO2, even though if we follow the permissive hypercapnia where the CO2 levels we accept up to 60 to 65. Beyond that, if the pH is still dropping less than 7.25, and if the pressures are, the saturations are not being targeted, even up to 93%, probably that is a time when you'll have to think of high frequency.
Yeah. So I think so, Jain understood. I'll go to the next question. How to wean from volume guarantee mode of ventilator? Is it different from pressure?
No,
He is asking two things once again. How to wean from volume guarantee? What is it? Normal and BPD. He is asking both he is asking. Maharashtra, Rahul.
Okay. See, there is a trick here. I mean, see, if you are using the pressure support ventilation, where the inspiratory time is set by the baby and even the rate is set by the baby, you are just set the tidal volume, the set targeted tidal volume. So only thing you need to do is if the baby is maintaining the set tidal volume with the minimal settings of FiO2, then I think probably that is the time when you can plan to extubate. If the baby is on SIPPV with volume guarantee, the same things apply. If the baby is on minimal pressure and minimal FiO2 and the baby is able to maintain that tidal volume, whatever you have set, and it is maintaining the saturation and the blood gases are good, probably that is the time when you can extubate. These things, it is one thing is it's very difficult to give a uniform guideline because it depends on independent babies. But if these basic parameters are met, then probably there's a time to extubate the baby.
Yeah. Prashanth, Ashwini Bandha.
Sir, internet is having a problem.
Okay, no problem. No, we'll go. Because continuously asking questions, that is the reason. He should not feel bad, speaker. Okay.
No worries. Please feel free.
Okay. How to, boss, you got another 4 questions. You have to bear with me, please.
No worries. Go ahead.
How to synchronize in SIMB? I heard it synchronizes in only inspiration. What about expiration? Bishop from Delhi.
No, see, synchronized mandatory ventilation means you are setting the rate here. So you try to understand the difference between SIPPV and SIMB. Now SIPPV, if the baby is breathing 60 times, even if you set a backup rate of 40, if the baby wants 60 breaths, the ventilator will give 60 breaths. So, and it will synchronize each breath, each of the 60 breaths will be synchronized when the baby is breathing. That is the importance of keeping the sensitivity of the trigger. Now, when the baby is on SIMV, suppose you keep a backup rate of 40 breaths, the ventilator will give only 40 synchronized breaths. The remaining, even if the baby is breathing 60 times or 70 times, another 30-40 breaths may not be synchronized. That is one thing. And second thing is, the trigger sensitivity is the most important. Whenever there is a negative pressure created in the circuit, that is how these ventilators sense that baby wants to breathe. So that's when it will give the breath. So usually it is the inspiration which will be synchronized, but The pressure support ventilation mode has come mainly because of this reason, because suppose you are the baby, you are giving a breath to the baby. At that point of time, the baby wants to expire. The baby will not be able to expire. Whereas if it is on pressure support ventilation, it will immediately sense that the baby wants to expire, and it will cause flow interruption or flow termination, and this is how a synchronized expiration also happens in pressure support ventilation. I hope I'm clear with this.
Yes, yes. So Dr. Bishat, I think so you heard the last one word what he told is the main anchor in your question. There is called termination sensitivity. Termination sensitivity. Otherwise, if the termination sensitivity would have been not there, you cannot go for, I mean, machine, or even it won't synchronize with the expiration. Number one, that is called termination. You please go to the machine and stand in front of that. What is termination sensitivity? You read the book, whether it is 15%, 25%, 30%, 70%, 80%. There is, please read it and try to understand. So termination sensitivity is the answer for inspiration, sorry, for expiration synchrony. For inspiration synchrony, trigger sensitivity. Okay, I think so. There is one more question for Prashanth. Okay, trigger sensitivity. This is from Singh, Pranajit Singh, Pranajit Singh, Punjab. Okay, how to set trigger sensitivity? Is it the same like a pressure mode, or is it different in the volume guarantee?
No, it is very similar. There is no trigger sensitivity, has got nothing to do with the volume controls. See, trigger sensitivity will assist in the ventilator sensing a respiration. So you have to keep it at a sensitive level, that is the sensitivity should be high. So if it is a SLE 5000, the recommended trigger level is around 0.6. If it is a dragger baby log, you can't go below 1. 1 is the highest sensitivity, and you can keep increasing if you want, because sometimes what happens is if you keep it at a very low sensitivity, then the number of triggering may increase and the baby may continuously breathe inadvertently, or your CO2 levels can start dropping. In those situations, you may have to increase the trigger, by that reduce the sensitivity of the trigger. So that is what is important to know, but that has got no role in the volume. Volume is a totally separate thing. So trigger sensitivity is mainly for your breath, that is for your SIMV or SIPPV or the pressure support. Volume, it is only to set the particular tidal volume, that's all.
I think so. Dr. Prashanth is asking if you will set the trigger, is it a pressure trigger or flow trigger? I think so. What his question means.
See, it is usually the pressure trigger. Hello, which ventilation, which ventilator, that is important.
No, in volume guarantee, I think so. It's a flow trigger, dear.
No. Which ventilator? See, it depends, because if you have flow termination and all that is when this one it senses the negative pressure in the system. That is when it triggers the breath.
So one more thing. This is from Pondicherry, from the same person. Sir, I am studying in Jipmer, Pondicherry, Surya, Dr. Surya, DM. I am doing DM. Okay, what is your question? What is difference between PRVC and VAPS? Oh, what is the difference between PRVC and volume assisted pressure support ventilation? What do you mean by that? Oh, PRVC and VAPS.
I think I have given a detailed explanation of that. PRVC and the volume assisted pressure support. Now this volume assisted pressure support is usually available in the Philips ventilator, where the pressure support ventilation is combined with volume ventilation. So that's why it is called as volume assisted pressure support. Now PRVC is pressure regulated volume support.
So volume control, pressure regulated volume control. So there also the way it senses and gives the volume is only the difference, but there is nothing. But at the end, they will all deliver the set tidal volume, whatever you have kept.
Yes. So, Dr. Prashant Taras, can I add one more word for it?
Yeah, please go ahead.
Yeah, Dr. Surya, you are from Pondicherry. You told full biodata you gave. Thank you, dear. Okay. PRVC, pressure regulatory volume control, according to me, what I know. When I was using servo ventilator 300A, now it is there in servo I. Now it is there in servo N also. That you know what is N. Servo I ventilator means all are maquette. Servo I, servo 300, all are maquettes. Previously it was Siemens. Now it is maquette. Servo
I think
300.
put a slide on all the ventilators where it was available also. So
Yeah.
previously it used to be called as Siemens. Now
Siemens,
they call it a servo I.
Servo I and
Yeah.
servo N. See,
Yeah.
one thing, PRVC, pressure regulatory volume control. I think so. Pressure regulatory, that is also pressure is regulated. Volume is also what you said. But only one thing is, in that mode, it is only assist control. You cannot use the pressure regulatory volume control in SIMV. And PSV mode, you cannot use it. But if you will go to the volume regulatory or TTV or volume targeted, whatever Dr. Prashant Taras is telling, everything is synonymous word, but slight difference is there, that's all. In that, you can use in assist control, you can use in SIMV, you can use in PSV also you can use. But PRVC, it's only in assist control. That's all one thing you should know. But one more thing, what you should know is in PRVC, the measurement will occur on near the ventilator. But in volume guarantee, measurement will occur near the ETT. So it is more sensitivity. So delivering the tidal volume is more accurate in the volume guarantee than PRVC. So number one, you should know the PRVC and volume regulatory difference. Number second, you asked another question is, I think so, VAPs. That is also what sir was telling Philips. Yes, it is true. It is available, but only in this is volume. If it is not able to deliver, machine automatically turns into the flow. That time, inspiratory time will prolong. So expiratory and inspiratory means cooperation won't be there. That time inadvertent volume chances is there. So that time what happens, only during the inspiration, there will be synchrony. But during the expiration, that synchrony won't be there. But newer machines in the Philips, what it has released last year, in that, he also added termination in that. Termination sensitivity, what sir has told, I think so previous question. He added into that, but still it is not able to control VAPs, that is volume assured pressure sensitive, the pressure support. I think so all the questions is over. Dr. Prashant, you have to take her questions also, please, because she is not able to connect.
Can I add something?
Please sir, please.
See, I added in the, I told in the talk also, see, most of these ventilator companies, what they are trying to do by this is just to avoid the patent problems. So most of, if you read through all this volume ventilation, most of them achieve the same thing through different routes. There is not much of a huge difference, nor do we know that which one is better than the other. And also to compare, that is the reason I put that last slide, to show that there are not many studies, randomized control studies done on the modes, and neither do these ventilator companies fund any studies like pharmaceutical companies to study these different modes and to really determine which one is better than the other. So that's why I always tell everyone to become proficient in their particular ventilator which they are using. So nobody expects everybody to know every other ventilator, because the differences may be very, very minute. Ultimately, what you want, the volume ventilation, the target what you set, the basic tidal volume what you want to deliver, if that is being delivered by your ventilator, Probably these are all just terminologies which there is slight difference in their technique, but may not make a big difference in the ultimate survival or in the morbidity or mortality of the neonates. So I think still I would all advise all of them to be proficient in their ventilators which they use, because every other 6 months to 1 year, all the ventilator companies will try to add one additional mode and come and try to sell it to you saying that this is a better mode. So this is what is happening. So thank you very much for giving me an opportunity, and thanks for all the audience for being patient with me. Thank you.
Yeah, thank you, Prashanth. Dr. Prashanth?
Yes, sir. Yes, sir.
I think so. There are questions is asked from Dr. Charan for her. She's not on the line, right?
No, sir. No, sir. Internet issue. She's unable to join. You can answer on
how to prevent microsensor damage, because everybody, even we do use normal saline. How to prevent it? So number one, sir, it is difficult to prevent it, because if you'll go to the Fisher and Paykel, because even I have bugged them what to do. So they are also telling the same thing. See, we are also using the normal saline, but chances of microprocessor, if you will immediately after every day use, keep it for 10 minutes in a very diluted soap water, such that whatever the normal saline is having salt, it will sit on the filament will go off. How many we people are doing? We use for 3 days, 4 days. Then once again, if the sister is not dipped in that water, within 3, 4, 5 months, if luck is there, it will go for 3, 4, 5 or 6 months. Otherwise, it will go off. They are charging 28 to 30,000. Some companies are charging 60,000. 60,000. So what one company is recommending, sir, you have to use the normal saline only. And some company told, sir, we are using distilled water. So it's up to us. But if your sister is very dedicated, normal saline is better. Number one answer for AP Vijayawada Charan. The another one, how to prevent rhining in tubes. We have problem. Dr. Ramalingam from Madurai, Tamil Nadu. Ramalingam from Madurai. Sir, it is the answer could be like this. How to prevent rhining? Sir, one thing already Dr. ASWINI has explained very, very clearly, very detailedly. How? What? See, one thing, near the chamber, there are two things are there, sensors. One sensor is, it takes from the inspiratory, that other side near ETT, where we are fixing. The another one is what it is going on here. The internal processor will mix it. So near the chamber, what that two processor, what you are going to fix it, there it will be 44 degree will be there. 44 degree, it will, near the inspiratory place, where that you are putting the temperature probe, that will give 37 degree. Suppose if you are keeping that ETT in, what is that, expiratory and inspiratory limb in the humidity, incubator, that time incubator will have some humidity and the temperature. That time what happens, that temperature will sense it is already heat here. So that chamber temperature will cut off that, or other thing will happen. That time temperature in the tubings will alter, number one. That is okay. But if you are not using in the inspiratory limb, there is coiled, spiral, heated wires will be there. If you are not keeping that, you will have a rhining. Rhining means, like if we will take bath, when we will take the towel, that time we are going to the, mirror. That time whole mirror will be having the fog. Because when you are taking the bath, there hot water is coming. When that hot humidity is going near the, somewhere on the surface, it will become cold. It will sit. Once it becomes cold, so maximum humidity or water content sits. What happens on this thing? It will start dropping. That is called a dew point. Dew point. So please try to understand what is dew point. Like that, in the tubes also, if you are not using properly coil, or if your wiring is mistake, you will tend to get the maximum water. Please, you look into that, sir. So the third question, is there any temperature difference between NIV and invasive ventilation? NIV, invasive ventilation. I think so, non-invasive and invasive. I think so. This is from Abdullah from Kanyakumari. Sir, I think so. I don't think we are using for both the things 37.5 or 37-degree temperature only, sir. Because 38 or 36, whatever it is there, previously some books were telling 34, but we are using 37 only because recently we heard it is 37 only we should use. We are using 37 only. Okay. In NICU for low flow oxygen, we do not use humidification, but we use 5 to 6 days. Is it okay? No name. From where? No name. Sir, I think so. Less than 2 liter, according to the books, according to the things what I read, we don't need any heat moisture exchanger HME, or any humidification is not necessary. Okay, that is written. But you are using, even I am using 5 days or 6 days sometimes, but I never read like that. Can I use it? But only I read less than 2 liter doesn't need humidification, no problem. That's what I am also using. Sir, I will look into that. If 5 to 6 days, if I'll use, do you think I need humidity less than 2 liter flow? I am sorry. If anybody knows anything, please add. Prashanth?
Yes, sir. Yes, sir. Yes, sir.
Unmute everybody, right? Okay. Then thank you. Thank you. Thank you. Prashanth, I think so. Guru Prasad irbeku illa yarna irbeku. Nodu. Thank you, Dr. Prashanth URS, and thank you, Dr. ASWINI, BIDARI, ANIKETH. Then thank you, everybody. Thank you, Dr. Prashanth.
Thank you, Prashant.
Yes, sir.
Thank you, Dr. Dinakar.
No.
Kotreshi, sir.
Hello, Prashant and Dinakar.
Yes, sir.
Well done, and excellent talk by Prashant URS and Dr. ASWINI, both. And regarding the humidification, I think the basic things most of us we neglect and we don't take care. We realize the importance of distilled water and as well as normal fluid. And what is the, even the Dinakar was telling, a 2 liter of this only lot require much more important. So very good work has been done by Dr. ASWINI. And on behalf of KNF, I thank for our speakers and Dinakar and Dr. Prashant also. Well done.
Thank you, sir.
Yeah, thank you very much, sir. Thank you, Prashant URS, sir, for your wonderful talk, and a wonderful talk by Dr. ASWINI as well. It was indeed a great presentation, and all this are available in Facebook and YouTube, so anybody can access this information. So we request all the participants to take part again. Day after tomorrow, we have good topics which is coming up. Thank you very much on behalf of NF Karnataka State Chapter. Thank you, Dr. Dinakar, sir, for moderating and anchoring the session. Thank you.
Thank you.
Yeah, thank you, sir.